And I suppose our aim with the CPC is to present a teaching case, but it's really one of these challenging cases that we see clinically where we're all scratching our heads. There's a lot to think about and discuss, and it's ultimately the pathologists that guide us in the correct direction. And this is really one of those cases that had us all quite confused. So this was a 30-year-old man who was transferred to the Brigham from an outside hospital for management of acute kidney injury. And he had a 3 to 4 week history. So 3 weeks prior to admission, he developed an upper respiratory tract infection with fatigue, mild sore throat, dry cough, and low-grade fever. Over the following week, he developed progressive lower limb edema and was seen at his local emergency room. He was diagnosed with acute kidney injury with a creatinine of 2.87 at that time. He had new onset hypertension and proteinuria. They treated him with some diuretics and labetalol, and he was discharged. After discharge, he developed increasing abdominal girth over the following week and re-presented to the emergency room. At that time, his creatinine was up to 3.88. He had a potassium of 6. His blood pressure was uncontrolled, and he had proteinuria. The urine dipstick from the outside hospital was reported as 3+ protein, and his urine showed 11 white cells and 16 red cells per high-powered field. There was concern that he had a rapidly progressive GN at this point, so he was given pulse methylprednisone. He was given 250 milligrams by 3, and then was transferred to the Brigham for further management. So in terms of his past medical history, he had ADD. He'd been taking Adderall, 20 milligrams daily for several years. He was also taking naproxen. He had no known drug allergies. In terms of his family history, his parents were alive and well, and there was no family history of any kidney disease of any sort. He lived with his girlfriend. He was a mechanic, a non-smoker, didn't really drink that much alcohol, and denied any illicit drug abuse. So on physical exam, when he arrived to us, his blood pressure was 162/80, his heart rate was 85. His weight was 331 pounds, and he told us that his dry weight was somewhere around 270, so he was significantly up. His SATs were 95% on room air, and he was afebrile. Clinically, he looked to be overweight, but it was in no distress. He had no icterus or pharyngitis. His JVP was 10 centimeters. Cardiovascular exam was unremarkable. His pulmonary exam, he had clear lungs but was dull at the bases bilaterally. On his abdomen, it was quite distended but non-tender, dull at the flanks but no palpable organomegaly. He had 3+ edema really all the way up to his hips. He had abdominal striae, which he said were new, but no rash or edema, and neurologically he was normal. In terms of labs, when we saw him, sodium was 133, potassium was down to 5.4, chloride was 96, his bicarb was 15. At that point, his creatinine was his BUN was 151, and his creatinine was 3.9. He had a glucose of 122 with an anion gap of 22. Calcium was 7.8, his phos was up at 13, his mag was up at 3.2, total protein was 5.3, his albumin was just 2.2, and his globulins were 3.1. His liver bloods were also a little off. His bili was 0.8, but his ALT was up to 40, AST was 69, and alk-phos was 299. His white cells were 8.89, hemoglobin 12.7, platelets 250. In terms of his workup, his ASO was positive. Complement C3 and C4 were both normal. His B12 was low at 130. And his homocysteine was elevated at 26. His spot urine protein was 40 and spot creatinine was 171. In terms of the urinalysis, when he came to us, so spec grav was 1.014. He had 1+ blood and 1+ protein with negative leukesterase, and his sediment showed 5 to 10 red cells, 3 to 5 white cells, and just some hyaline casts. So our questions, which we had to deal with in taking care of this patient, and questions for the discussant are, what is your differential in this type of presentation, and how would you approach this patient? Dr. Sarnak, thank you very much.
Thank you very much, Martina, for inviting me to discuss this case. I was very glad that from the outset you said my primary goal is to give the differential. I think I found this case extremely difficult to come up with a definitive diagnosis, but I'll try and give you a differential as to how I would have approached it, and what are the potential causes. So these were what I thought were the objective findings of the case. 3 weeks ago, he had an upper respiratory infection, sore throat, cough. There was a question of a fever. And almost immediately afterwards, he started developing progressive edema and weight gain. So relevant that this happened almost immediately. His physical exam, to start off with, he was obese. Well, although I don't come back to that, I'm not sure it's necessarily relevant to the case. He has high blood pressure that seems to be new, and he has edema that's new. He has increased creatinine. I'm assuming that this is a new increase in creatinine, that he didn't have some baseline CKD, associated with obesity-associated FSGS or something like that. And notably, his serum albumin is at 2.2, which is quite low. He has a normal C3 and C4. The ASO is positive, but I wasn't given a titer. His UA on the 2 different occasions showed 5 to 15 red blood cells and 3 to 11 white blood cells per high power field. There's no mention of dysmorphic red blood cells or cellular casts, either red or white cell casts. And the only measure we have of the proteinuria, or detailed measure of the proteinuria, is 0.23 gram per gram. And I think this is kind of relevant. If anything, I would have thought in acute kidney injury that the ratio would be higher than you expect if the creatinine is not getting in the urine. So this is not nephrotic level of proteinuria, at least at the time when it was measured. I think it's hard to say if there was something going on before he actually had a detailed measure of proteinuria. And interestingly, the urine says hyaline casts as well as waxy casts, which I generally think are pretty non-specific findings, although sometimes we think of waxy casts as in a little bit more chronic disease. So when we think of acute kidney injury, which I think we have to make the assumption this is acute kidney injury, at least we saw the creatinine start going up from 2.87. We always teach everyone, the fellows, the residents, to think of pre-renal causes. So we're always going to think about that. I don't think that would be presented to me in this type of forum. Intrinsic renal disease, is definitely part of the differentiation, and I'll go into focus a little bit more on that. Post-renal causes, again, possible if there was, obstruction due to crystals or something like that, but these, both pre-renal and post-renal, seem less likely. Most tables, when you think of the intrinsic renal diseases, you talk about tubular necrosis, interstitial nephritis, and acute glomerular nephritis. This is actually taken from a New England Journal review by Dr. Bonaventri and Ravi Thadhani. And you usually add ischemia and toxins as the cause of acute tubular necrosis. Over here, I just added vascular disease to this intrinsic renal disease, and I'll mention why I think that is something at least to consider. So how do we go about this? When we see acute kidney injury, we all go and we look at the urine studies, we review the urine under the microscope. We generally say if it's pre-renal causes, there's minimal proteinuria, the urine's bland, urine osmolality tends to be high because of ADH stimulation, FeNO tends to be low because of renin-angiotensin stimulation. ATN due to nephrotoxins and ischemia, classically we see pigmented granular casts. Urine osmolality may be down to 300. If there's, significant tubular damage, the FeNO may be high. I always teach our fellows that there's often a lot of overlap between the pre-renal and the intrarenal, especially if you don't have oliguric renal failure. In other words, we see a lot of patients with low FeNOs and pigmented granular casts in the urine. Acute interstitial nephritis, we'll have mild levels of proteinuria, hematuria, leukocytes. Classically, we see white blood cell casts, maybe see eosinophils. But this is, with the allergic AIN. There's some kinds of AIN where we don't see the white cell casts. We may only see a few white blood cells. So AIN is often a diagnosis that we make on the biopsy. Acute GN, we'd like to see a reasonable amount of proteinuria, some red blood cell casts, or acanthocytes. And post-renal, it really depends at what stage we catch them after the obstruction. So this is what I was hoping would be given to me, but none of the data I was looking for was in the presentation. So I was hoping someone had looked at the urine, using phase contrast, or looked at it carefully and had seen some acanthocytes, these Mickey Mouse cells. That would be a little bit more suggestive to me of a glomerular disease. Alternatively, we may have seen something like this, red blood cell cast, which would at least push me in the right direction as to in the differential. Maybe we could have seen this. Maybe someone could have told me there was a white blood cell cast, and I would have been happier with my presentation and more confident that I was actually going to get it close. So when we think about this, is this a primary glomerulonephritis or primary tubulointerstitial disease? Or is it perhaps neither? So what actually makes me think that this is a glomerulonephritis, or what's in support of glomerulonephritis? Patient has, quite significant hypertension coming in, and I'm impressed by the significant edema and weight gain. If the patient's giving the right history, I'm thinking acute kidney injury can do this, but I would say a little atypical for a tubulointerstitial cause of acute kidney injury. So this was more suggestive to me of a GN. Hematuria and proteinuria, there is some proteinuria, there is some hematuria consistent with a GN, and the serum albumin struck me as being very low. Not to, it's 2.2 and the spot protein to creatinine ratio is not consistent with that, but is it possible he had more proteinuria before, or is there something else that's making him lose a lot of protein in the urine and resultant hypoalbuminemia? From the tubulointerstitial disease, there's no dysmorphic red blood cells, there's no red blood cell casts. The proteinuria really doesn't seem that impressive, at least when it was checked. So this is the approach I would have taken to think about the different types of diseases. So when we think about red blood cells, if we're able to look at it carefully through phase contrast, how good are these tests for glomerular versus non-glomerular etiologies? So this is one study published in The Lancet in 1982, 303 patients with microscopy by phase contrast. If you have greater than 80% dysmorphic or greater than 80% non-dysmorphic, those are pretty good indicators of a GN versus a non-GN respectively. But it's important to note that of the 115 with proven GN, only 29% had red blood cell casts. A lot of them had proteinuria greater than 1+ on dipstick, but as many as 21% had no red blood cell casts or proteinuria. So, it's not definitive that this is not a GN if we don't see dysmorphic red cells or we don't see red blood cell casts. This is another study published in Kidney International looking at glomerular and non-glomerular etiologies of hematuria. And if you've got greater than 5% acanthocytes, those are much more specific for GN than other red cell abnormalities. At least on the first look, the sensitivity is 52% for a GN, and specificity is actually quite high. And if you repeat the urinalysis again and again, you can get the sensitivity a little bit high. So it turns out this urine it's not definitive either way for glomerulonephritis or tubulointerstitial disease with what I've been given thus far. So let's think about some of the glomerular causes. What are some of the glomerular causes that could cause acute kidney injury, retention of salt and water, and edema? So we generally think of it like this: antibody-mediated, using pathological criteria, immune complex GN by electron microscopy, linear staining that you often make a diagnosis on the immunofluorescence, and then porci-immune, where on electron microscopy you don't have many immune complexes. Of the immune complex diseases, we need to be thinking of all of this. IgA nephropathy, HSP, systemic version, there's no history to suggest any of this. Lupus, Post-strep GN, we do have a little bit of a clue of that. MPGN or C3GN, now I know you've had some lectures on this, cryoglobulinemia-associated GN. If it was linear staining, on immunofluorescence, we would think about anti-GBM disease, and you may send an anti-GBM titer. For porcine-immune, you're going to send ANCA levels, and then anti-proteinase 3, anti-myeloperoxidase, depending, on your initial screen for the ANCA levels. On top of that, when we think about GNs, we generally try and evaluate the complement levels. So the complement levels, low complement will help us and suggest low post-strep GN, post-infectious GN. There's some history that suggests that he may have had some low-grade infection when all this started. You may think about an MPGN, lupus, cryoglobulinemia. And then the ones that are normal complement levels are IgA, ANCA-associated GN, and anti-GBM. There are other things that cause low complement levels without necessarily having an immune complex GN, and those could be liver disease. He has a little bit of liver disease. He has, if there was HUS, TTP, some of these, can have low complement levels, and atheroemboli. No suggestion in the history for atheroemboli. And this patient kind of fits in the criteria of normal complement levels, at least based on the levels that we have. This is modified from Brenner et al. And what you can see is there are a lot of causes of, RPGN, MPGN, MPGN 1 and 2, or, our current C3GN, different versions of this. They usually have low complement levels. Fibrillary GN will have normal complement levels. IgA will have normal complement levels. Anti-GBM and ANCA will usually have normal complement levels. So I focused a little bit on the red ones, highlighted in red, because we had normal complement levels in this patient. But there are a lot of, as we go through the case, there are a lot of clues here that I have to try and work out, are they relevant or are they not relevant? So could this be post-strep GN? We were told that there was a positive titer for ASO. And what is in support of post-strep GN? Sore throat, acute edema after the presentation, hypertension, there's some proteinuria, there's pyuria and hematuria, and the ASO was positive. So that's in support of it, and this could be post-strep GN. The proteinuria may be a little bit lower than I would expect for the degree of edema. Edema too quick after presumed infection. We usually think of this happening, 2 weeks after a strep infection where you start developing the kidney manifestation. The UA doesn't have dysmorphic red cells or red blood cell casts, although this is clearly described that it's possible in post-strep GN. As I've mentioned, the urine are not definitive unless you've got 80% one way, 80% the other way. The thing that was bothersome to me from a strep GN was usually in the first 2 weeks, the C3 in particular is decreased in about 90% of cases. The C3 normals were normal in this patient, and then they usually return to normal 4 to 8 weeks later. He's not quite at this, not quite here yet, if I count the amount of weeks. So this was a little atypical for me, that was not consistent with post-strep GN. ASO, how sensitive, how specific? So 80% of patients with post-strep GN will have a rise in the ASO titer. In patients with if you really suspect the GN, but with an undetectable ASO titer, you should test for the other anti-streptococcal antibodies. In this case, it wasn't relevant because it was positive. But remember, the ASO tells you that there's been a strep infection, not necessarily a GN related to strep, and so specificity for the GN may be lower. I mean, it doesn't tell you what's going on in the actual kidney. And we don't have a titer. This is the part that bothers me a little bit more. Is this a low-grade increase or is this a big increase? And the titers can actually vary with age, season, geography. Some people will just have, low-grade titers that are where they are the whole time. So that's my thought about the GN. Could this be a tubulointerstitial disease? So NSAIDs is a classic cause of tubulointerstitial disease. And we know that NSAIDs can cause both a nephrotic syndrome and an AIN at the same time. It's classic or notorious for doing that. It can cause a minimal change nephrotic syndrome and a membranous nephropathy in association with AIN. But I think that would be very strange. This guy's taking it once a month. It's possible. He had he's got a nephrotic syndrome and he's got AIN. By the time we see him, he clearly doesn't have nephrotic syndrome anymore. So maybe he had NSAID, nephrotic syndrome, AIN, gained the weight, has stopped it, and the nephrotic syndrome's gone. I think very unlikely. I mean, that seems a way stretch even for what I'm pushing in this. There are many drugs, obviously, that can cause interstitial nephritis. I particularly looked up the Adderall, and I couldn't find any reports. But I have been tricked by Martina before. Previously, when I did this, there was a case that was the first time they were presenting something. So maybe they know something about Adderall that I don't yet. Autoimmune diseases, SLE, sarcoid, Sjogren's, tubulointerstitial nephritis, these are all causes of acute interstitial nephritis. We don't have that much history to suggest it. IgG4-related diseases, you'll notice that the globulin levels were normal. Often these patients have low complement levels. There's not much else to suggest it. There's no nodes that they're talking about. There's no pancreatitis, nothing else. And the degree of, as we said, edema seems out of proportion. Infections, any type of infection can cause an interstitial nephritis, but again, not much history to suggest it. Other causes of tubulointerstitial disease, myeloma, kidney or cast nephropathy. This one, occasionally we've been burnt on this. There hasn't been any clues in the history. Again, there's no suggestion here. The patient's not overtly anemic out of proportion to the kidney disease. The calcium's normal. The globulins are normal. I think this is unlikely. But we have occasionally made a diagnosis of a myeloma kidney when we don't, if we haven't sent to SPEP, UPEP, or light chains or something like that, and made the diagnosis on the biopsy. Oxalate nephropathy, this is another one that occasionally, clinically, I've run into without suspecting it before. This was mentioned as one of the cases during the lunch. There's primary hyperoxaluria, which usually presents at a young age but can present at older ages. And then there's secondary hyperoxaluria, associated with very high oxalate intake, star fruits, we mentioned spinach, things like this. Usually there's some form of bowel disease or previous bowel surgery that would make you susceptible to it. Again, the level of fluid retention seems atypical for this kind of thing. And there's not much history here that would make me think about oxalate nephropathy. Now, vascular disease is something I think we need to think about, something like thrombotic microangiopathy. And I definitely think this needs to be in the differential. It will cause AKI and have hematuria. It's more unusual, but some will present with high levels of proteinuria and edema, right? We've all seen people with antiphospholipid who have aggressive proteinuria, with antiphospholipid in the kidney. We've seen people with receiving VEGF inhibitors and some endothelial dysfunction. They'll have aggressive proteinuria and acute kidney injury. This patient obviously can't be pregnant or have help, but you could imagine a similar kind of presentation with acute proteinuria, retention of fluid, and some damage to the kidney. Against this there's no evidence of thrombocytopenia, no evidence by what we're given of microangiopathic hemolytic anemia. So it's hard to push this diagnosis, but like I said, I think we've got to think about this a little bit when there's proteinuria without red blood cell casts and some acute kidney injury. So I think that needs to definitely be in the differential. Exactly what's causing this, I would have no idea. So as I'm thinking about this is when I was starting to get frustrated, and I'm trying to think, how do I use all the information that's been given to me in this case? And then there's some strange findings that are noted. So why this patient has low B12 levels. And this seemed to be a clue, although not clear to me how it was a clue. Who gets low B12 levels? So people with gastric abnormalities, pernicious anemia, someone with small bowel disease. someone with pancreatitis, someone who doesn't take in enough B12, and agents that block absorption of B12. From the history, I don't get any of these. I mean, I could put together a story on any of them, but I don't see how they related to the case. Which kind of kidney diseases may be associated with low B12 through affecting the gut? So you could imagine if he's got IgA, he may have celiac disease and have low absorption of B12. Oxalate nephropathy comes back again. You know, if there's some bowel disease that we haven't diagnosed, he could have low B12. IgG4 related diseases can affect anything, including the gut, and you could have low B12. You could put together a story of autoimmune conditions that are associated with pernicious anemia and may affect the kidney. So this is Martina, and I'm trying to think, is Martina nice, or is Martina trying to catch me out now? And I still am not sure, and we'll see a little bit later exactly what Martina's, if Martina was nice or Martina was not giving me enough information. There are some other clues here. He's a mechanic. He was exposed to heavy metals, example, lead. You know, you always want to get the work history. Lead, it can cause acute toxicity. That's associated with anemia, abdominal pain, high uric acid. Usually not acute kidney injury, more a Fanconi type of syndrome. We don't see any of that in the UAs. Chronic toxicity, hypertension, gout, CKD of unclear etiology. Again, tubulointerstitial, there's too much retention of salt and water in this case. So I think this was not relevant to the case. There's some other clues that I don't actually think are relevant, but I'm sure I'll learn if they're relevant. The alkaline phosphatase bothered me. It was primarily alkaline phosphatase of the liver enzymes that were elevated. So I'm thinking most likely liver-related. There's no bone disease that I can think of in this patient. The acute kidney injury is too acute for this to be bone-related alk phos. Perhaps may point to a tubulointerstitial related to primary biliary cirrhosis or infiltrative disease of the liver. So you could imagine sarcoid or something like that may be causing the alk phos to go up and the kidney function to go off. Liver disease definitely doesn't seem that bad to suggest hepatorenal syndrome and fluid retention from that. The accumulation of fluid in the abdomen on the physical exam did, however, seem a little strange to me, but it was probably just general fluid retention everywhere. The stria, Martina mentioned that in the presentation, and it was written in the presentation. Just if you retain fluid, you're going to start getting stria. You know, there are genetic factors that can do it. There are hormonal factors. We all think about Cushing's disease. Cushing's disease, I can't put that together with the stria. So I think this is just a physical factor, retention of fluid, and he started to develop some stria. The Adderall, the Adderall for attention deficit disorder can definitely cause hypertension. That's one of its side effects. But this doesn't seem to be hypertensive crisis with acute kidney injury. We don't see thrombocytopenia. There's no mention of microangiopathic hemolytic anemia, due to severe hypertension, any other end organ damage. And I couldn't find anything on the Adderall causing, a glomerular lesion. But like I said, you always got to go look that up. The high homocysteine is kind of fascinating. Personally, I think people with CKD all have high homocysteine levels. I didn't particularly look up AKI if that causes high homocysteine levels, but I assume it does in similar ways. You're all aware of the VA study treating homocysteine. The levels are all high up when your kidney function is off. Patient has low B12 levels from causes we listed earlier, and that obviously is going to be a cause of high homocysteine. Now, there's strange cases that have been in the literature, things like cobalamin C deficiency or inherited disorders of B12 metabolism. They can cause elevated levels of methylmalonic acid and homocysteine and low levels of methionine. I'll show you a slide. And the renal complications may include a TMA more commonly, but also there have been reports of glomerular lesions. So B12 levels should not be low in this condition. So if you look at a slide, this is a paper in AJKD, this cobalamin C disease over here. the cobalamin levels or the B12 levels themselves should be normal, but you have high homocysteine and you may be at risk for a thrombotic microangiopathy. So this is me on the weekend on vacation getting extremely frustrated with this case and not liking it that I don't know the diagnosis. How did I put it together? You know, this is my feeling as to what's most likely. You know, if you had to take into account the most common types of kidney diseases, I would say IgA nephropathy. This is unlikely to be the diagnosis because I think they won't present IgA nephropathy to me. But if I was looking at it before the biopsy, I would say this is my most likely diagnosis. There's a synpharyngitic presentation of AKI, so there was, presented with a cold and upper respiratory symptoms, immediately started running into trouble. There's blood and protein in the urine, low serum albumin, edema and hypertension, and IgA can be associated with GI disease, something like celiac sprue. Ruling out on the diagnosis, I'm a little bit concerned about thrombotic microangiopathy, or some form of endothelial injury that's causing a lot of initial proteinuria and low albumin and retention of salt and water. Post-strep GN still in the differential. Fibrillary GN, there's no clues that we have, but could always be part of the answer. And oxalate nephropathy I've kept in. I don't like a tubulointerstitial disease as the primary cause over here with all the edema, the hypertension, and the retention of salt and water, but I think, like I said, occasionally we've seen patients that we've been surprised with oxalate nephropathy. What additional info would I want? I want to know the race. I mean, if it's an Asian person, I may feel a little bit stronger about IgA nephropathy. I want people to look at the urine again with phase contrast. I want a blood smear. Are there any schistocytes? Maybe the platelets are still normal. Is there any evidence of hemolysis? We always got to check HIV, which can masquerade as anything. Obviously, I want to anchor ANA, hepatitis serologies. I want a 5' nucleotidase. I just want everything, right? 5' nucleotidase or GGTP. We need to image the liver. He's got abnormal ALK-Phos, other LFTs that are abnormal. I would do a SPEP, UPEP, and light chains. Lead level, I think, is much less likely, but if you're really thinking about lead nephropathy. And ultimately, we want a kidney biopsy. Now, the one little issue over here, and I'm interested to know how they went ahead over here. It's not clear to me from the presentation the exact trajectory of the kidney function. The BUN is way out of proportion to the creatinine, and I suspect it's primarily because of some high-dose steroids for several days. This patient is at quite high risk for bleeding with a biopsy. He's got reduced GFR. These are the primary risk factors for bleeding. Reduced GFR, acute kidney injury is much higher risk. He's anemic. His anemia is not too bad. Older age is a risk factor, doesn't apply to him. And obviously, if you put in a bigger needle, you're more likely to bleed. At Tufts, we don't do the bleeding time, but you could consider doing a bleeding time, give him DDAVP either way. And, depending on, if there's any uremic signs or his bleeding time is very high, you may do dialysis first, get this uremia out of the picture before you do the biopsy. But this is kind of a judgment call. I don't think there's a definitive answer to that. So that's the way I put it together, and thank you.
Okay, so let me tell you what it is. This is always the case. Any other suggestions from the audience? Does anybody, and now you even have a picture here on low power. You can tell already that it's not AIN, but just to go back to some of the things that Mark kind of like alluded to, yeah, we would not really give you an IgA nephropathy case. So most of the serologies were negative. I think HIV was done, that was negative. ANCAs were negative. There were no schistocytes, as far as I know, on a peripheral smear. So this is a very difficult case, and I really give you that, and I think it's one of those cases which you probably just want to do a kidney biopsy and really figure out what it is. But as you will see, actually, even the biopsy is not that straightforward. So here you have pretty low power of this biopsy, and actually here in, do I have actually a pointer? Oh, this moves. Okay, good. So here, this is a capsule in upper right corner, and you see actually relatively well-preserved parenchyma underneath. Slightly higher power or intermediate power magnification, and you see actually a couple of glomeruli that don't look normal, but you see also tubules are kind of like back to back, not much interstitial inflammation. So to go back to the discussion before, this is not really AIN, or at least, you know, so far we didn't see any kind of like significant interstitial infiltrate. But the glomeruli, again, they don't look normal. I'll get to them in a second. And actually here on this magnification, you can see this glomerulus that appears very hypercellular. You also see several tubules. Some of them are slightly distended. Here you have a little bit of cellular debris in some of the tubules. So there was a little bit of acute tubular injury with cellular debris. And here is to your oxalates. This is an H&E. So previous slides were all PAS stain. When you are looking for oxalates, you do want to look at the H&E stain section because you don't see it on stain slides. Here you have a glomerulus. And you see this little crystal over here. And then this is the same section just under polarized light. And you see there is a little crystal here. So this really doesn't make a diagnosis of oxalate nephropathy, but yes, he did have a rare kind of like deposition of oxalate crystals, so really not very significant. So again, even here you see a little bit of tubular injury, no significant interstitial inflammation. Let's get back to the glomerular business. So you see that this glomerulus is hypercellular, the capillary walls are kind of like thickened, there are just a lot of cells here, and when you start actually looking at what these cells might be, you will kind of like think, okay, you know, like this is some kind of either GN, so with infiltration of, or endocapillary hypercellularity due to inflammatory cells, or this could be just really very reactive endothelium. So I personally would vote for endothelium here rather than inflammatory cells, and I'll tell you why. If you look at actually outside here, you see a couple of lymphocytes, and you can actually see how lymphocytes are small and really dark. And these cells don't look like that, so they are not really lymphocytes. Here's another glomerulus with a similar kind of a picture. And again, when you look outside for lymphocytes, you see actually they're small and dark, and these cells are really not. So it looks like really what we call endotheliosis, and what you would see really in, usually in pregnant women. And first thing when I looked at this biopsy, I said, you know, like, is he pregnant? And they assured me that he was not. But, you know, this is kind of a picture that you get. So it's not your typical thrombotic microangiopathy with, you know, like widespread, you know, fibrinoid necrosis, thrombi, this and that. And you don't necessarily expect to see schistocytes on peripheral smear in this type of picture either. So this is like endothelial dysfunction and widespread glomerular endothelial injury. And practically every glomerulus looked like this. So I was actually even surprised that he was able to produce any urine, given the fact that it looked like this. Also on immunofluorescence, as you can see, there was no immunoglobulin deposition, and I actually didn't put other stains, but I just show you here IgG that was negative. C3 was also negative, so it's not C3GN. It's not post-infectious GN, which would be a good kind of a guess given the history. and that hypercellularity. But when you see that hypercellularity and you think it could be, you know, your acute GN of some sort, you should see some deposition on immunofluorescence, and there was really none. So everything was negative, and I'm just showing IgG and C3. Fibrin was positive in this kind of fashion, so it supports the diagnosis of endothelial cell injury. So when you see this kind of like dull type staining, it's not really thrombi or anything like that, but it just kind of like stains everything like that. We see that more commonly in endothelial cell injury. And then EM really was really amazing, and the most incredible endothelial injury you could imagine was presented in this case. You can actually see, so this is relatively low power, but you can see that every loop is kind of like distorted, and when you go on higher power on any of these loops, this is what you would see. So this is, so I'm kind of like losing this pointer, but this is original basal membrane over here. These are podocytes on the outside, so this is urinary space. This is a podocyte nucleus here. There is complete effacement actually of food processes. And then under the basal membrane, instead of seeing endothelium right here under the lamina densa, you actually see that there is this fluffy distortion of the subendothelial space, and then endothelium is right here. And actually this here is a red cell. It's kind of like entrapped in that fluff there. So there are no really subendothelial deposits, but you see this remodeling of the capillary with tremendous subendothelial widening, and the endothelial cell appears very injured. There are no fenestra, they're swollen, and so on. So every capillary practically looked like that. So this is what you would see in acute thrombotic microangiopathy. And here's just more of the same thing. You can actually see this is a capillary, but this is where the lumen practically is now. So this is why you didn't see anything on light microscopy. You really didn't see open capillaries. Everything is kind of like closed or obliterated by these very swollen endothelial cells and this subendothelial swelling and widening. So we summarize this as severe acute thrombotic microangiopathy with prominent and widespread endotheliosis. It belongs in the same group of diseases. And I know that the term is really kind of like confusing because you're trying to find evidence of thrombosis and you really don't have that, and we should probably change our terminology. But this is just one of the morphological expressions of this disease, I would say, when you have this diffuse endothelial injury and swelling, and the differential diagnosis is practically the same. So a number of different conditions can look like this, and these are the hardest diseases to diagnose. So once I say, okay, you know, like this is what you have, you then actually start looking for, you then go back to your patient and looking for really what caused it. And in this type of a setting, when you have a young person, I always say that there are really most commonly the scenario would be that you have a person with some kind of genetic predisposition, genetic defect, whether it's in you know, alternative complement pathway or, you know, like B12 metabolism, that is on top of it actually undergoing some other hit. So there's a second hit, and most commonly in young people, it's a drug. Cocaine, amphetamines, and so on. So this is a type of a picture that we had in this case. But again, you know, like for renal pathologists, this is, you know, like when we see the type of a case like this, it's easy for us to say, yes, you know, it's endotheliosis, it's thrombotic microangiopathy. But going back to the case and trying to figure it out is really the hardest thing. And I think, you know, Mark did a great job, you know, like with doing this before the biopsy with the little information that you had. So I would stop at this point unless there are questions about the pathology. Everything was clear, everybody figured it out. Okay, so Martina. Oh, you have a question. There is a question. Yes? I didn't show the vessels, but what was very interesting, actually, small vessels were fine. So arterioles and arteries were totally fine, which is very unusual, actually, for when we think about vasoactive substances like amphetamines or cocaine and whatnot. We always think that they actually act at the larger vessel rather than microvasculature, where you would get, like that constriction that causes it. But no, there was no really evidence of it. I mean, and it's hard to tell unless, you had really vasoconstriction that was acute, and then you can't really tell on a biopsy, so there was no repetitive injury that would end up with sclerosis or thickening of the vessels. Maybe there was not enough time for that. So that's a good point. Do you have a question too?
How about the GBM? What do you comment on the GBM?
So the GBMs, oops, which way am I going? No. Oh, okay.
Wait a minute. You want that back?
No.
Hold on.
So,
You want your slides back?
Yeah.
so the GBM was very abnormal just by the fact that the subendothelial space, which is lamina rara,
There you go.
thank you. So lamina rara interna was tremendously widened. But the GBM in itself is very irregular and wrinkled, which you get with hypoperfusion and, is just part of the remodeling. So even when you go on this picture, you can actually see that there is just, and, people usually talk about double contours in this kind of situation. When you have very acute event, you don't actually necessarily see it. I like to refer to those changes as remodeling of the capillary, and some of it will be acute, some of it will not. But the GBM is really just that lamina rara interna is the one that suffers here. And this is what you notice when you have widespread endothelial cell injury, that lamina rara interna just swells up, and then endothelium builds a new basal membrane eventually, but this was too soon, so it was not really evident. Okay.
Can we get mine up then? So thank you very much to Dr. Sarnak. We gave him a very difficult challenge, and I think it's a great example of how when you have an expert clinician who goes through things step by step and takes it in great detail, that you can really narrow this down, even the very difficult cases. But this was one of the ones where when Vanessa called us with the pathology, we kind of said, really? Thrombotic angiopathy? And then, as she said, we had to go back to the patient and say, okay, well, how do we make this fit? And what actually, what has caused this? So in terms of follow-up, what happened to him over the next couple of weeks? Subsequently, his hemoglobin did decrease to 8, but this was in the setting of critical illness, post-renal biopsy. Platelets fell briefly to the 130s, but again came back up. But his hemolytic screen was sent several times and was always negative. Because of this concern for drug-induced endothelial cell injury, we sent a tox screen. It was negative for cocaine. It did show amphetamines as he was taking Adderall, but everything else came back normal. His autoantibody screen, as we said, was negative. An Adams TS13 was sent, which was mildly suppressed at 60%, but really this is not significant enough to be of, would change our clinical management, and his complement levels were also normal. So because of the finding on biopsy, then, obviously now we have a drug that can treat thrombotic angiopathy, so, the question is, should we use it? And there was a discussion about whether we should start him on eculizumab or not, but the thinking at the time was, well, look, his hemolytic screen is negative, his platelet count's quite stable and plumb normal, and and really the decision ultimately was not to proceed with that because it didn't fit for us entirely with the systemic thrombotic angiopathy. So he was simply started on B12 replacement, put on low-dose diuretics, was readmitted within several days with worsening volume overload. At that stage, got very aggressive diuresis. All this abdominal distension went down. He went from being what looked like a very obese guy to a fairly normal-sized guy. And over the subsequent week, his renal function started to settle. And by about 4 to 6 weeks post-biopsy, his creatinine was down to 0.9. So we're still back looking at, well, what actually caused this. And as Vanessa said, the thinking being, was this someone who had an underlying tendency to have endothelial cell injury, and then there was a second hit? So could the second hit have been the Adderall? So he was sent for testing for abnormalities of the alternative pathway. His membrane attack complex was marginally elevated at 0.31, where normal is less than 0.3. I'm not sure that this is really a robust finding that we could pin our hats on for this. His factor H autoantibodies were negative, and his complement assay was also normal. His C3 nephritic factor was negative. And he's being sent for genetic screening for abnormalities of complement regulation. That's still pending, but in the absence of a functional abnormality on the testing, again, it would be kind of difficult to interpret those. So, again, why does he have endothelial cell injury? And our thinking is very similar to the way the Mark approached it. Why does he have a low B12? Why has he got this high homocysteine? Could there be something there? And we also came back to this condition of cobalamin C deficiency. And I think the way I thought about this was not that necessarily this is what he has, but I've seen this several times over my career where you come across these rare inherited diseases where they usually present in pediatrics with this very fulminant condition, but then over time there's an appreciation that you can have much more subtle presentations of similar abnormalities of pathways that we see in adults. And, could this be something like that that's going on? So there have been a couple of cases reported in the last couple of years of hemolytic uremic syndrome associated with cobalamin C deficiency, and these are just two from the renal literature. So one that they tried with eculizumab didn't work because it, for whatever reason, and then the second was a renal thrombotic angiopathy that was also associated with pulmonary arterial hypertension. So the pulmonary artery bed was also involved. So what is cobalamin C deficiency? It's a rare autosomal recessive condition with a mutation in the MMACHC gene causing a defect in B12 metabolism, typically with normal B12 levels, but with elevated levels of the downstream metabolites. And in the recessive form, presents in the first year of life with this very severe neurological problem with the developmental delay, excuse the typo. Late onset cases are seen in children up to the age of 4, but there are some adult onset cases, usually with neurologic disease, but can also present with atypical HUS, often with pulmonary hypertension, hyperhomocysteinemia with the normal B12, with the methylmalonic aciduria, and serum methionine can be low. And I think there are two things maybe that are, one that's relevant to this case and one that's relevant, I think, for me more broadly, thinking as a practicing nephrologist. For this case, is there some potential abnormality that, with the hyperhomocysteinemia, that there could have been some vascular injury, maybe with the Adderall as well, in someone who had a predisposition? There's a certain amount of hand-waving in that, but maybe that's a potential causative pathway. But the other thing, thinking more broadly in terms of looking after patients with thrombotic angiopathy, this is not something that's on my radar, and perhaps we should think about it, because I think 5 or 10 years ago we would all have said atypical HUS is extremely rare, but since now we've got a drug to treat it, we are picking these cases up. So similarly, these cases may be out there, we may just simply be missing them. So thinking about adult presentations of atypical HUS from these types of rarer genetic abnormalities may also be relevant to our practice.